We are going to start.
Hello, everyone. A big welcome to all of you online joining this Mindray U-Master webinar entitled Liver Elastography. I am Kenny Ng. My current role is responsible for Mindray Ultrasound Luminary Program. It's my great pleasure to be here with you as a moderator for this webinar. To begin this webinar, allow me for a few housekeeping items. First of all, on behalf of the U-Master webinar team, every one of them and myself would like to extend our sincere appreciation to our speakers and also to each one of you online from different regions, from different locations, time zone differences, connecting to this exciting Mindray global webinar platform. Your ongoing participation in continuing educations and interest encouraged Mindray very much of our commitment to stay connected with you during this pandemic time with our academic and education webinars. Now, as you expected, this webinar has two parts. The first part will be lectures from our distinguished speakers. And the second part, I would like to emphasize, we love to hear from you, as there's time allocated for Q&A sessions at the end of the lecture for audience who submit their questions to the speaker. You are encouraged to submit your question in your chat box on your screen, and as much time is allowed, the speaker will take the questions at the end of the lectures. Now, you may be also pleased to hear this and would like to introduce it to your associates that this webinar will have a recorded version. And they simply can go to Mindray Ultrasound under the U-Master column, enjoy watching the recorded webinar at their time. Now it's my great honor to introduce our faculty featured speakers. In addition to the very nice speaker introduction slides that you have seen, many of us already know our speakers are well-known, renowned radiologists who dedicated and devote themselves in clinical researches, publications, speaking engagement, and active clinical practice across all ultrasound applications, particularly in ultrasound elastography. Professor Paulos Sompoulos, he is the founder and CEO of EchoMed, a leading imaging center in Athens from Greece. And Professor Zhang Wei, she's from Guangzhou, China, the very prestigious, the third affiliated Song Yat-sen University Hospital Ultrasound Department. And we're extremely privileged to have a special guest, Professor Zhang Yongqian, to join us at the Q&A sessions after the lecture. Professor Zhang also is from Guangzhou, China, the third affiliated Song Yat-sen University Hospital, a leading research center for many advanced medical applications. Truly, these speakers are academic masters and clinical experts in the field of liver elastography. They are the ideal expert speaker to speak to us. With that, now I ask that we give them our full attention, and also with our receptive, good spirit to welcome the first lecture by Professor Sompoulos, and his lecture title is Quantitative and Qualitative Ultrasound Methods in Evaluation of Chronic Liver Disease, and followed by Professor Zhang Wei. Her lecture topic is Liver and Spleen Stiffness Measurement by STE-STQ in Evaluation of Liver Fibrosis in Patients with Chronic Hepatitis B, a multi-center China study. Now, please help me to give them a big welcome. And Professor Sompoulos, now I turn to you to start your lecture. Thank you.
Hello, everybody. I'm Pavlos Zumboulis, radiologist, CEO of ECOMED, a day clinic specializing in ultrasound and elastography in Athens, Greece. This is the overview of my presentation. We are going to pass through a clinical overview. Then we're going to discuss technology approaches of elastography. Of course, we're going to discuss technique of shear wave elastography and sound touch elastography. And then we're going to comment about how inflammation and steatosis of the liver acts on elastography measurements. And finally, we are going to find ways to overpass limitations of elastography through a mathematical multiparametric ultrasound model. Chronic liver disease is one of the major causes of death and the major cause of hepatocellular carcinoma. Many injuries, infections, alcohol, and others may act on the liver, and during this long period, depending on mainly on epigenetic marks, arrives to liver failure and portal hypertension, passing from inflammatory damage and finally through cirrhosis to disrupted architecture and loss of liver function. But in nowadays we have the possibility to follow through elastography the different way through the removal of the underlying cause and through antifibrotic drugs. After cirrhosis, we know that there is a development of hepatocellular carcinoma, and in this case, the only treatment is liver transplantation. Liver biopsy is considered as a reference standard, but it has serious limitation. The main limitation is the sampling errors. Imagine this is the needle. This is a histology image of the liver with the regenerating nodules. The blue is the fibrotic tissue around the regenerative nodules. If the needles cuts a specimen from here, you see that this is a practically normal liver parenchyma, like this one with minor fibrosis. But if the needle cuts in this segment, this is it is mostly containing fibrotic tissue, meaning that that this is going to be a specimen like that. In the same liver, different places of liver biopsies give very different results. There are important sampling errors with liver biopsy. Happily, ultrasound elastography and MRI elastography are now present in order to solve this issue. This is an anatomy and histology correlation from the normal liver through small account of fibrosis towards cirrhosis with regenerative nodules. And there is an analogy between each stage of fibrosis and the elastography color mapping corresponding to different measurements in kilopascal. Histology versus imaging modality. Of course, histology is the reference standard. A fibroscan is the old elastography, performing well mainly for stiffness and fibrosis, of course, but also for steatosis. Ultrasound, because of shear wave elastography, performs better because it offers during the same examination morphology, hemodynamics, stiffness, and of course graining of fibrosis and steatosis. MRI is good enough but very expensive. CT is not good for fibrosis and steatosis estimation. Those are the causes of chronic liver disease and fibrosis. Please note that viral hepatitis B and C and non-alcoholic fatty liver disease are the main causes of chronic liver disease. In those hepatology, fibrosis staging based on shear wave elastography alone is enough. Practically all those patients are going to avoid liver biopsy. In those more rare entities, we usually need liver biopsy, but only as an initial evaluation. Why estimating liver fibrosis is crucial? Because we need to risk stratify patients for treatment because we want to prevent fibrosis progression. We need to identify high-risk CLD patients. We need to identify those same patients for liver cancer surveillance, and we need to provide prognosis for patients and providers, especially prior to surgery. And we need also to monitor the effect of the regression of fibrosis, because now we have drugs, DAAs, direct acting antivirals, in order to treat those chronic liver diseases. There are guidelines and recommendations from many medical societies, starting from the European Federation of Societies of Ultrasound. I'm going to emphasize only three. Find an intercostal space and use the B mode before applying shear wave elastography. Your hand and your probe, of course, has to be stable. The same immobility has to be valid for the liver. There are reliability indicators in order to solve the issue of intra and inter-observer variability. This is the reliability index. This is a color map helping you placing the region of interest in a specific place. Of course, the color mapping of elastography alone may be enough in order to place the region of interest in the right place, but this is the five stars stability index, indicating that the lever at the moment of measurement is stable without a movement. Examining a normal lever, please avoid the rips and the shadows. That means that your transducer is not well placed. Only change the orientation of the transducer like this one, and then you have the possibility to place the region of interest of elastography here. And finally, you are going to have in real time reliable measurements of shear wave elastography using both reliability and mobility index. Those are frames from shear wave elastography of the normal lever. You recognize those compression artifacts. This is a case of HBV patients for antiviral therapy indication. Those are the clinical facts and the labs. The patient's question is, do I need antiviral therapy for my HBV? And the physician's question is, does she have significant fibrosis? The decisive test to do is, of course, shear wave elastography and STE. And if the result is no significant fibrosis, that means that this patient does not meet the criteria for antiviral therapy. An HIV patient with those clinical and biochemical data, the question of the patient is, what medication do I need? For how long? Do they have side effects? Does my insurance is going to cover the cost? And the physician question is a simpler one. Does he have advanced fibrosis or cirrhosis? The decisive test is shear wave elastography, and the result is advanced fibrosis and cirrhosis, meaning that this patient needs antiviral and antifibrotic therapy. He is also at risk of developing hepatocellular carcinoma and needs surveillance. These third cases on a very common illness, alcoholic liver disease, where fibrosis and steatosis coexist. There are two issues with livers having important steatosis. The first is that in challenging obese patient, shear wave elastography measurements are difficult to obtain. And the second and more important is that important steatosis increases shear wave elastography measurements And let's explain a little bit more the example of alcoholic liver disease, and compare how fibrosis and steatosis, their evolution is through the long run of ALD. Starting from the normal liver, the ALD patient starts to present steatosis more and more. In the middle of this long trajectory, there is coexistence of fibrotic tissue and steatotic one, and finally, when the fibrotic tissue starts to progress and becomes more important, arriving finally to cirrhosis. At the final stage, cirrhosis, meaning important fibrosis without no steatosis. We can having now the possibility to treat both fibrosis and steatosis, we can use shear wave elastography in order to run the same way, but to the opposite side. Another factor, another intrinsic factor influencing shear wave elastography measurement is inflammation. Active necroinflammatory process adds 2 to 5 kilopascal in all shear wave elastography measurements. And research is currently ongoing in order to determine a separate ultrasound index for inflammation. Tissue viscosity may be one such a parameter, because with viscosity we can study how nano and micro particles react when an ultrasound beam arrives to the tissue. Those are grades of inflammation from 0 to 3. Imagine how complicated the situation is if there is coexistence of inflammation and fibrosis. With elastography alone, we cannot discriminate those two pathologies. Speaking about cutoff values, please retain this simple rule of 5. 5 kilopascal means normal, up to 10 kilopascals means important fibrosis, up to 15 kilopascal means compensated cirrhosis, and more than 20 kilopascal means decompensated cirrhosis with portal hypertension, and there is an important risk of varices needing treatment. But there are limitations of ultrasound elastography in chronic liver disease. The limitations start from the fact that fibrosis estimation alone is not enough for a chronic liver disease diagnosis and grading. The cause is because shear wave elastography measurements correlates to liver stiffness and not to the liver content in fibrotic tissue. We can, in this anatomical presentation, we can find how many intrinsic factors intervene to elastographic measurements. One is the fatty infiltration. One important is the active liver inflammation. Those two factors are increasing shear wave elastography measurements. There are also extrinsic factors acting on shear wave elastography measurements. One is cardiac failure causing dilatation of the hepatic veins and the inferior vena cava, and this pressure ends to increasing shear wave elastography measurements. Other cause of extrinsic compression to the liver are dilatation of the portal vein and the important dilatation of the bile ducts. Let's see a case about that to discuss how in these patients with chronic cardiac disease, there is of course dilatation of the inferior vena cava and the hepatic vein. If we pass to the elastography mode, it is very easy to see that there are many different values of elastography in the same liver segment. And the reason is that the compression, there is a periodical compression of the hepatic vein on the liver parenchyma, acting as a force to increase or decrease shear wave elastography measurements of the liver. Multi-parametric ultrasound means that we may use other ultrasound parameters in order to make shear wave elastography measurements more reliable. B-mode is such a parameter in two ways, because of course you know that B-mode image is guiding shear wave elastography measurements to place the region of interest in the right place, but also B-mode image can deliver liver and spleen morphology. Those morphologies are crucial for chronic liver disease and portal hypertension grading. Chronic liver disease is a very complex illness. Not only the liver is involved, and many morphologic, biochemical, hemodynamics factors are inter-influenced. Therefore, shear wave elastography is not sufficient for such a complex, ever-changing process. But ultrasound offers to us more information on morphology, on hemodynamics, and on elastography. A neural network may integrate all those parameters in order to achieve in more reliable measurements and better grading of fibrosis. Let's speak about the morphology of a cirrhotic liver with liver lobulations, and the B-mode alone is enough to show what is happening in the portal vein, because the portal vein is a factor of influencing liver stiffness. Hemodynamic study is very useful, not only for what is happening in the portal vein, but also what is happening in the hepatic veins, meaning that the hemodynamics may also interfere in shear wave elastography measurements. Of course, the cornerstone of fibrotic content grading is elastography, passing from normal normal measurements to fibrotic, and finally to cirrhotic liver measurements. Multiparametric ultrasound through machine learning is the tool that we propose in order to conclude this presentation. It is no doubt that shear wave elastography and sound touch elastography is a reliable biomarker for liver stiffness and fibrosis estimation. Since stiffness is not synonym to fibrosis, there are other intrinsic and extrinsic factors interfering, and those are necroinflammatory process, steatosis as intrinsic factors, and a portal vein and hepatic vein pressure as extrinsic factors. This is a schematical way to show you how morphological information, hemodynamic information, and elastographic information may enter to this artificial neural network. It is the responsibility of this network under strict rules of training in order to exit as parameters the grading of fibrosis, steatosis, inflammation, and portal hypertension. Machine learning is a tool for identifying association between different ultrasound parameters, morphology, hemodynamics, and elastography, and through the output parameters of the artificial neural network, fibrosis, steatosis, and portal hypertension. Thank you for your attention. We hope to see you again during the next Mindray webinars at this day. This is the temple of Apollo in Delphi. Only 3 columns are remaining like that. Imagine that the whole thing represents the possibilities of ultrasound. We have already 3. B mode for morphology, a color Doppler for hemodynamics, and elastography for stiffness and fibrosis measurements. And as we have already discussed, but we are going to have time to discuss during the next webinar, new columns are starting to evolve for steatosis grading and for portal hypertension staging. Thank you very much.
Good evening. It's my great honor to share a multi-center study in China about liver and spleen stiffness measurement by STE and STQ for evaluation of liver fibrosis in patients with chronic hepatitis B. China is a country with big hepatitis B incidence. There are over 88 million chronic hepatitis B patients in China, which have made China tops the world of hepatitis B infection, and about 1 million people die of liver-related complications every year. The progression of chronic hepatitis B is strongly associated with the presence of liver fibrosis. Ultrasound elastography assessing liver stiffness is of great value in evaluation of liver fibrosis. It can be used to guide treatment, evaluation of therapeutic effect, and follow-up monitoring. Although liver biopsy retains the traditional reference method for assessing liver fibrosis, ultrasound elastography can be partial replacement of it. We previously organized a prospective multicenter study from January 2015 to June 2016. 17 large hospitals participated in this study. The research objective was to evaluate the diagnostic accuracy and diagnostic cutoffs of supersonic imaging two-dimensional shear-wave elastography for liver fibrosis in chronic hepatitis B patients. Ultimately, a total of 402 chronic hepatitis B patients from 12 hospitals with reliable liver biopsy results were included. It was found that the diagnostic accuracy of 2-DSWE for liver fibrosis is different in chronic infection and chronic hepatitis status. The area under the receiver operating characteristic curve in the chronic infection group was significantly higher than that of the chronic hepatitis group. 2-DSWE was most effective in ruling in and ruling out cirrhosis in patients with chronic infection, which may guide antiviral treatment. As indicated in elastography guidelines, stiffness measurements are system-specific, and different diagnostic cutoffs for different technologies, etiologies, and populations should be developed. Sound-touch elastography, a two-dimensional shear-wave elastography, and sound-touch quantification, acoustic radiation force impulse imaging. Two technologies are on the same platform. Ultra-wide beam tracking technology and dynamic pixel focusing were used. Corresponding diagnostic cutoffs should be made for the new technology. Thus, we organized a multicenter study with large sample to establish the diagnostic cutoffs for liver fibrosis. This was a prospective nationwide multicenter study spearheaded by Chinese Society of Ultrasound Medicine. The co-principal investigators were Chinese People's Liberation Army General Hospital and the third affiliated hospital of Sun Yat-sen University. 30 hospitals from China participated in this multicenter study. From December 2017 to October 2019, preparation meetings, research protocol determination, elastography operation training, case collection, quality control, and research summary were accomplished. In this multicenter study, two technologies, including STE and STQ, were assessing simultaneously. Liver pathology analyses were all performed in a third-party professional center by two experienced doctors. Online database was established to upload data, including baseline characteristics and images. The study was approved by the Institutional Ethics Review Board of each participating institution and registered online by principal investigators. These would be important evidences for prospectiveness of this study. After 3 rounds of discussions and many times of revisions, the protocol of the study was finally confirmed. Every part of the protocol has gone through rapid deliberation to make sure the protocol would be scientific, reasonable, precise, and feasible. Study methods including elastography, pathological diagnosis, and clinical data collection were determined uniformly in advance. especially for elastography, standardized operation protocol, unified image acquisition and storage methods were developed. During image acquisition, depth, focus, scale, and size of elastic box were settled. The standards were made according to preliminary experimental results, previous researches, and guidelines. High-quality mode and credibility mode was adopted during image acquisition. Green in credibility mode referred to good credibility and the region of interest should be put at this area. Credibility index should be no less than 90%, and motion stability index should be no less than 4 stars to avoid interference of respiratory movement. Conventional ultrasound exams were performed before the elastography measurements. 10 images of liver capsule, parenchyma, and vessels were acquired and stored. 5 liver STE, 5 liver STQ, and 5 spleen STE were performed on each patient. All images were stored as the format of DICOM. All-sided and strict quality control were conducted through the whole process of this multi-center study. Effective communication and timely feedback significantly improved the qualified rate of elastography, pathology, and database. Systematic and standardized training was implemented at the beginning of our study. All investigators received standardized operation protocol training to obtain images, including theoretical study, operation demonstration, and everyone must pass the test before the multicenter study started. 2 doctors from our center with at least 300 cases of liver ultrasound examination experience and at least 50 cases of STE and STQ examination experience were in charge of quality control. Before starting, 3 times of independent STE and STQ operations and 2 times of data uploading exercises were accomplished by each operator. Then the quality controllers would check the images of the first 5 patients of each operator. During the entire process of the study, the quality controllers would regularly review data. Quality control of pathology is the key point. To avoid difference between observers, all biopsy specimens were collected to a third-party professional institution and analyzed by 2 pathologists specialized in liver disease with more than 6 years experience and were blinded to the clinical data. Staging of chronic viral hepatitis was assessed according to the Metavir scoring system. Criteria of reliable pathology results were biopsy length no less than 10 millimeters and no less than 6 portal tracks. Establishing online database led to convenient data uploading, unified data format, and efficient and convenient quality control. Multiple channels of communication were built so that problems could be solved timely. After 15 months of case collection, 26 centers had uploaded valid cases, a total of 870 effective cases, and 620 qualified cases, including patients with and without antiviral treatment, were obtained. Following are some results of this multicenter study. Part 1 was to determine the cutoff values and compare the accuracy of liver stiffness measurement obtained by STE and STQ for assessing liver fibrosis with serological markers. No more volunteers and participants of multicenter study were included. The normal volunteers were randomly allocated into two subgroups for the comparison of applicability and repeatability of STE versus supersonic imaging and STQ versus acoustic radiation force impulse imaging. It was found that intra-observer agreement of STE and STQ was similar to that of SSI and RFI, respectively. Detection duration of STE and STQ were significantly shorter than that of SSI and RFI, respectively. Patients in each fibrosis stage had significantly higher median values of liver stiffness measurement by both STE and STQ than those with a lower fibrosis stage. The optimal cutoff values of liver stiffness measurement performed by STE and STQ for predicting significant fibrosis and cirrhosis were found, and both showed significantly higher diagnostic accuracy for cirrhosis compared to serological markers of liver fibrosis. There was no significant difference between the diagnostic accuracy of STE and STQ. When compared with the results of our previous multicenter study of supersonic imaging, the diagnostic accuracy was similar. In short, STE and STQ are reliable and fast liver stiffness measurement detection methods. STE and STQ can be used as valuable non-invasive tools to exclude significant fibrosis and cirrhosis in chronic hepatitis B patients. There were no significant differences between STE and STQ for diagnosis of liver fibrosis. Part 2 aimed to assess feasibility and reliability of spleen stiffness measurement performed by STE and to evaluate the effect of liver inflammation level on value and the diagnostic accuracy of spleen stiffness measurement for cirrhosis. And the feasibility and reliability of spleen stiffness measurement performed by STE were compared with spleen stiffness measurement performed by supersonic imaging and the liver stiffness measurement performed by STE, respectively. Definition of invalid measurement, technical success, reliable measurement, and splenomegaly were made according to previous studies. In single-center group, a total of 40 values of spleen stiffness measurements were acquired in 20 patients performed by 2 radiologists with STE and SSI, respectively. Success and reliable rates of 2 technologies were both 100% in splenomegaly patients, while in non-splenomegaly patients, success rate and reliable rates of STE were higher than SSI without significantly difference though. The multicenter group success rate and reliable rate of spleen stiffness measurement showed no significant difference compared with liver stiffness measurement. There was no significant difference in success and reliable rate of spleen stiffness measurement between splenomegaly and non-splenomegaly patients either. Independent factors of technique success was age and small splenic axis. Independent factors of reliable measurement were BMI and large splenic axis. For inter-observer agreement, intra-class correlation coefficients of spleen stiffness measurement by SSI was significantly higher than spleen stiffness measurement by STE in total and in splenomegaly group. However, there was no significant difference between SSI and STE in non-splenomegaly group. ICC of spleen stiffness measurement by STE was still excellent. For intra-observer agreement, ICC of spleen stiffness measurements by STE was significantly lower than spleen stiffness measurements by SSI in total, while no significant difference in subgroups. ICC of spleen stiffness measurements by STE was significantly lower than liver stiffness measurement by STE. However, all ICCs were higher than 0.9, which were excellent. ICC of spleen stiffness measurement by STE in splenomegaly group was significantly higher than in non-splenomegaly group, which were both excellent too. Liver stiffness measurement values were significantly higher in high pathological inflammation activity group. There was no significant difference in spleen stiffness measurements value between different pathological inflammation activity groups. Liver stiffness measurements values were significantly higher in high ALT level group. There was no significant difference in spleen stiffness measurement values between different ALT level groups. Area under the curve of spleen stiffness measurements was significantly lower than liver stiffness measurements for cirrhosis in all of the untreated patients and in subgroups with low level of liver inflammation. There was no significant difference between AUC of spleen stiffness measurements and liver stiffness measurements in groups with high level of liver inflammation. In short, spleen stiffness measurement by STE showed excellent feasibility and repeatability. The diagnostic accuracy of spleen stiffness measurements was lower than that of liver stiffness measurements in patients with lower ALT level and pathological inflammation activity. However, there was no significant difference between spleen stiffness measurements and liver stiffness measurements in patients with high ALT level and pathological inflammation activity. Spleen stiffness measurements values were also not affected by liver inflammation. It could be a good surrogate method for evaluation of liver cirrhosis, especially in patients with higher level of liver inflammation. Thank you for your listening.
Okay.
Good.
Yeah, hello. Hello, everyone. I'm Dr. Jen from the SET Affiliated Hospital of Sun Yat-sen University. I'm very glad to participate in this online meeting and discuss some interesting subject with doctors aboard. So now I would like to begin the Q&A. Okay. Should I begin?
Yes, Professor Zhang. Welcome you to the Q&A session. And we also have Professor Sompoulos on the Q&A session. So I would coordinate some of the interesting questions with two of your expertise and knowledge to help our audience. First of all, I want to thank Professor Sompoulos for your very expertise lecture and your very detailed update. Certainly help us to understand the multi-parameter of using ultrasound in assessing chronic liver diseases. And Professor Zhang, all the respect to your very scientific multi-center studies. It's an excellent study that really opens up a lot of answers and give us many solutions, I'm sure, to many daily practice using on the shear wave. So I have actually many good questions. Maybe I would want to start with Professor Zhang Yu first. All right. Your study, which you are the key author, and you also are the co-chair with such a extensive study. And can you help us to learn what are the key clinical information that you can share with our audience from this study when they do their daily 2D shear wave elastography, in assessing liver fibrosis? And then, we're going to listen to your comments from that study on that. Is that possible?
Mm-hmm. Yeah, actually, yes, I had received several questions from the audience, and they are all interesting about the 2D SWE of STE and the STQ that we had made the multi-center study. So first, I would like to explain about the 2D SWE scanning protocol for quality imaging and data acquisition. During the imaging acquisition by STE in Mindray, credibility index and motion stability index can be used for quality control. The green color in credibility mode refers to good credibility, and the credibility index should be no less than 90%. Motion stability index should be no less than 5 stars to avoid interference of respiratory movements. At least 5 times of consecutive measurements should be performed on each patient. The median value of consecutive measurements was regarded as the representative value. So according to all elastography guidelines, ratio of the interquartile range and the median range, that is IQR to median their value less than 30% is defined as reliable measurements. And also some audience, they are just concerning about the standards reporting and interpretation of the liver stiffness measurements. What should be included in the reporting? And I will try to give my comments and introduce our experience. It was stated in the Society of Radiologists in Ultrasound Consensus Conference Statement published in Radiology in 2015 that the reports for ultrasound-based elastography should provide the median value as well as the ratio of IQR to median value as measure of quality, turn out to improve reproducibility of series measurements. The patient's position and equipment used, both the machine manufacturer and transducer frequency, should be reported. So the interpretation should include several things. The first is whether these patients are at minimum risk of having clinical significant fibrosis, or whether these patients are at moderate risk and a high risk of significant fibrosis. Because for the lower F0 to F1, that is the lower minimum risk of having clinical significant fibrosis, this patient had no needs to follow up. However, for the high risk of significant fibrosis, the patients, for example, at the stage F3 and F4, this patient should be followed up. And in our experience, we in our reports, we included description, interpretation, and notice in the reports. So besides the description refers to the consensus, we also added some notice for the reference of the clinician. For example, we states that the standards is applied only to hepatitis B patients without antiviral treatment. And the second, we also states that pathological reference is metabolic staging system, and the reasonable interpretation should be made combining with clinical data. And also, we should notice that liver stiffness measurements value may be affected by jaundice, ascites, intestinal gas, obesity, and other factors, which is only reference for clinician. So, and the others audience, just the concern about the confounding factors that cause the variation in the stiffness measurements. So what are the methods for us to just reduce these confounding factors? So I think that developing a detailed and standardized operation protocol for liver stiffness measurements helps to address the confounding factors among operators to maintain accuracy. For example, liver stiffness measurements were performed after at least 2 hours of fasting or after at least 10 minutes of rest for our patients. The patients should have supine position when during imaging apposition, and the imaging depth was also we set to 8 centimeters, and the elastography scales was set to 30 kPa, and the size of elastography ROI was 4 plus 3 centimeters, and the diameter of the measurement ROI was 2 centimeters. So these protocols were all uniform and were settled down. And the elastography ROI should be placed in an area of the liver parenchyma free from large vessels and 1 to 2 centimeters, and the liver capsule of the right liver lobe. And the patients was instructed to hold their breath for approximately 3 to 4 seconds when the measurements value were being measured. The standards protocol were made according to our previous published study and guideline. So during our multi-center study, we all use the uniform standardized operation protocol. And the purpose of this protocol is to just minimum the inter-operator variances. And the last a question that the audience concerned, I would like to explain is about the overlapping of stiffness measurements vary from system to system. So what our best practice advice? I also would like to give my comments. The previous elastography guideline For example, if some guideline and recommendation on the clinical use of liver ultrasound elastography update in 2017 indicates that the diagnostic cutoffs of liver stiffness for fibrosis was system-specific and cannot be equaled across machines. So in our practice, the difference between different machines does exist. However, the difference was not so significant, I think. For instance, the cutoff value of supersonic image just we made in the former multi-center study in China for the hepatitis B patients and the STE cutoffs for the also for hepatitis B patients by a Mindray machine this year. The diagnosis cutoffs for cirrhosis was not has not bigger differences. For example, for SSI, the cutoffs for cirrhosis is 11.7 copper kPa, and for STE, the cutoff for cirrhosis is 11.2 kPa. So these cutoff values are not so they are very close. So I also just agreed to the update of the Society of Radiologists in ultrasound liver elastography consensus statements published on radiology just recently. They said that concerning the liver stiffness value, overlap of multiple staging is greater than the measurements variability between systems. So it suggests that separate cutoff values for each system are not required. So this is a very a large change. So it suggests from a clinical perspective, it is more important to rule in or rule out significant disease, the so-called rule of 4 kPa for the 2D SWE and PSWE for viral hepatitis. It suggests that liver stiffness of 5 kPa or less than 5 kPa has high probability of being normal, and the liver stiffness less than 9 kPa is just similar to our STE standard cutoffs. In the absence of other non-clinical settings, could rule out compensated advanced chronic liver disease. Value between 9 to 13 kPa was suggestive of advanced chronic liver disease, but may need further test. And the value larger than 13 kPa was highly suggestive of advanced liver disease. So I think maybe this is the new ideas for some expertise in America and European. And
Sure. Yeah. That's exactly, we need studies like yours to somehow find out where's the overlapping gap. Now, thank you so much for sharing the whole content of your study. And we all appreciate that from your study, your data point out that from system to system, there's a variation. And also from operator to operator, there's also a variation in terms of getting the stiffness data. And I have a next question actually relating to Professor Sompola's lecture. And shall we turn to Professor Sompolas for this question?
Yes.
Professor Sambolas? Yes. There's a question related to Professor Zhang's, study and also related to your lecture content. And please give your comment. I know you're a great imager. You do liver 2D shear wave daily, and the techniques on the shear wave, 2D shear wave reliability also related to intra and inter-observer variability. So for our audience on a daily practice, scanning the patient, could you please comment on this from your experience?
Yes, I would like to start first thanking Dr. Zhang for the nice presentation, and Professor Zhang for coordinating this study. It is really impressive to see such studies coming from China. To answer your question, yes, we all know that intra and inter-observer variability is an issue. But we can limit this issue first, respecting the guidelines, and second, observing the Mindrays and Arizona 7 reliability and immobility indexes. I would like to stress one point on that. Immobility, both of the hand and the probe, and immobility of the liver are crucial. The first thing that a beginner has to understand is that the immobility of the probe and the liver at the same time is the condition in order to do reliable shear wave elastography measurements and limit intra and inter-observer variability.
Thank you. Thank you very much. May I also have you comment the acquisition of a 2D basic liver image, how important it is before the operator go ahead and do the quantification on the stiffness value from your experience? How much, false positive and false negative would that create, if they sacrifice the quality of the 2D image? Please.
B-mode is the base in order to build everything on it. You cannot perform any shear wave elastography or sound touch elastography measurements without having at the beginning of the exam a reliable and steady B-mode image. B-mode image is not only guiding sound touch elastography, but also gives many information on the liver texture.
So, from your experience, how should the operator be sure that they are on the right liver location for the adequate BMO image before they activate the quantification measurements? Could you comment on that?
Yes. The positioning of the probe well into an intercostal space is crucial. In some patients, mainly in cirrhotic patients, where the right lobe of the liver is small, and the examiner should try to find a different intercostal space in order to have access in other segments of the liver, also in the segment 4, for instance. That's all. Okay.
Okay. So if we look at the Wolfram guideline, they said only qualified operator should be able to confidently perform, 2D shear weight. And the recommendation is that they should have done 500 cases of TE, 50 cases of 2D shear weight before, under observation, then before they can left alone to do by themselves. Now, is that realistic in a very busy imaging center like yours or in a very busy ultrasound department? I mean, how's your experience on that?
Yeah, we have two kinds of experiences. One is our center, which is specializing on the liver elastography. That means that we are doing 20 shear wave elastography per day. For a center like ours, it is those numbers that the World Federation of Ultrasound is mentioning are very easily achieved. We have also the second experience of somebody coming to us for working in a smaller center, where he's going to have only 1 or 2 cases per day, or maybe per week. We explain to those beginners that they have to stay with us, let's say, several days, in order to perform by their own, under surveillance and guidance of an experienced radiologist, in order to be able to perform reliable sound touch elastography or shear wave elastography measurements.
Okay. Actually, we recall that Professor Zhang, their multi-center study, they actually have a technical training for all the operators going to involve in that study. Shall we ask Professor Zhang to give, their insight? How did that program train the new operator to perform proper 2D shear wave examination? And then you can always comment thereafter, her, information to share with us. Would that be okay? Yeah. Professor Zhang?
Hello? Okay, thank you. Thank you.
Yeah, in your study, you mentioned that you have a training program for all the operators. So what's the protocol? Can you share with us, if somebody is new to do 2D shear wave, what should be the proper training protocol for them? Please.
Okay, thank you. So in our multi-center study, all investigators received standardized operation protocol training, including a theoretical study, operation demonstration, and they just see the demonstration first, and then every operator just practice for at least 50 cases of STE measurements. After that, every operator must pass a test before the multi-center study begin. So we found that because we found that before that the intra-operator and the inter-operator agreements of stiffness measurements performed by experienced operator was significantly higher than new operators. So we think training is very important. According to the IFOM guidelines, training for no clinician should insist on reporting standards. Interpretation should be performed by a physician with knowledge of clinical condition of the patients. The key issue is to obtain adequate competence and training to perform elastography in accordance with the medical legal regulation of the relevant country. It also suggests that the operator must acquire appropriate knowledge and training in ultrasound elastography, and data acquisition should be undertaken by dedicated and specialty trained personnel. For PSWE and 2D SWE, experienced in B-mode ultrasound is mandatory. So proposed definition for an experienced operator of 2D SWE, including having performed larger than 300 abdominal ultrasound scans, or at least 15 supervised 2D SWE examinations. So I think this suggestion is very useful for all of us. Thank you.
Very good. So you have a very clear protocol for them to follow. So maybe we can switch to Professor Sompoulos. You have additional comment on the training because Professor Sompoulos, I know that you conduct 2D shearway liver training course. You have something to add on to what Professor Zhang had just illustrated. The protocol training is very important. Please, can we switch to Professor Sompoulos?
Yes. The crucial point is that the technique, we can teach the technique only with a probe on our hand and in front of the machine. Nobody is going to understand the particularities of shear wave elastography and the way to apply shear wave elastography by lectures or by questions and answers. We have the trainee has to be in front of a machine, and his hand and the probe has to be guided by an experienced clinician in order to find out all the clues, and in order to be in the position to really guide his hand. You know, many shear wave elastography measurements during the same examination are false. Many of artifacts appear in every frame on every examination. Then, you know, all of that depends on small movements of the hand and the probe and the absence of movement on the liver. This information and this training can only be can only be real only with a probe in the hand and only in sitting in front of the machine and having a real patient in front of us. These comments are more important in front of a really a pathologic patient, let's say a cirrhotic patient, because there the condition of applying shear wave elastography are more difficult, and you cannot train somebody only in a normal liver. You have to train him or her on a pathologic liver, because in front of a pathologic liver, he is going to affront many issues, and he is going to try to solve under guidance those issues.
Thank you very much, Professor Sompoulos. Our time is actually running up to the end, and before I go to Professor Zhang for a summary statement from her, I also want to ask you first, would you like to give our audience a summary statement that you want to conclude on your lecture, and also about the information from the multi-center study? Please go ahead. Maybe in 60 seconds. Then I have to turn to Professor Zhang, because our time actually is coming to the close end of that. Yeah, please. Any conclusion statement from you, Professor Sompoulos?
Yes. First, start from the B mode. You cannot try to apply shear wave elastography without having a solid knowledge on how a B mode examination is done. B mode examination is the base of every shear wave examination. And the second thing I want to underline, stability of the hand and the probe, and immobility of the liver.
Thank you very much. We look forward to your second part of your lecture on the next webinar. Thank you. Now, Professor Zhang, you only had maybe 60 seconds. You have any summary statement you want to tell our audience before we close this webinar, please? Any summary for us?
Yes, thank you. I think standardized protocol for liver stiffness measurements is very important. Another is the interpretation should be combined with clinical data. It's also important. So thank you very much. Thank you for your attention.
We thank you so much for your sharing and the insight that you share with us about your multi-center study. It really is opening up a lot of solutions for many questions. And we thank you for your time to be here with us. Thank you so much. We hope to see you soon again.
Thank you, Kevin.
Right?
Thank you, Professor.
All right. Thank you. Now, I want to make a closing statement before we close this webinar. First of all, I want to thank you for 3 speakers. We are really privileged to have such expertise to inform us with such details. And also thank you to the audience, for your interest in STE and STQ technology. I hope from the speakers we learn better about this technology, and then we can bring better ultrasound healthcare to patients. And the next webinar will be on June the 23rd, and we'll definitely send out the information out. And on behalf of the Mindray UMaster webinar committee, we thank you for your time and for your attention. And once again, please stay safe, and we look forward to seeing you and connecting with you in the next webinar. Bye-bye.
Bye-bye. Thank you.
Bye-bye. Everybody stay safe.